Thank you so much for this wonderful honor to speak at your Retinoblastoma Symposium. I have no financial interest or relationships to disclose. And I'd like to talk to you about Retinoblastoma 2021. What is new? First, I'd like to give credit to all of the collaborators on the Ocular Oncology Service at Wills Eye Hospital who have helped in many of the studies that I will share with you. It truly takes a village to manage one case of retinoblastoma, and we have been doing this for over 50 years at Wills Eye Hospital. We provided in the Indian Journal of Ophthalmology a 2020 review of the modern treatment of retinoblastoma from Dr. Lazami, who's now in Monterrey, Mexico, Dr. Dalvin, who's now at the Mayo Clinic in US, and me. So I'll talk to you about three topics. What is new? It's all about chemotherapy. And I'll talk to you about chemotherapy for retinoblastoma, unilateral sporadic retinoblastoma, how to approach it, retinocytoma, what is the risk for transformation into retinoblastoma. So let's begin with chemotherapy for retinoblastoma. We all have our different tendencies for management protocols. We still use enucleation in Philadelphia for retinoblastoma if it's a no hope for vision or what looks like a high risk eye, or if the parents are unreliable or chemotherapy is not available. And we still use intravenous chemotherapy for bilateral retinoblastoma and intraarterial chemotherapy for unilateral retinoblastoma. Vitreous and aqueous seeds are treated with intravitreal or aqueous chemotherapy, and plaque radiotherapy is sort of our last go-to method if all of the above fail. So let me ask you 5 questions about intravenous chemotherapy. Does it work? Yes, it does. Do the results vary based on the International Classification of Retinoblastoma group? Yes, it does. Is it lasting to 20 years and longer? Yes. Do the results vary based on patient age? Yes. And what features predict recurrence? Well, I'll let you know. So regarding intravenous chemotherapy for retinoblastoma, it's used to treat the eyes, the brain, and perhaps even reduce systemic problems. Here we see a bilateral advanced retinoblastoma with total retinal detachment OU. Here is this same child. She's now 20 years old and her vision is 20/30 OD and 20/70 OS, and she has no metastasis. She was treated in our first year that we used intravenous chemotherapy. But really, does it last for all patients? Well, we published this in the British Journal of Ophthalmology 2020, long-term 20-year real-world outcomes of intravenous chemotherapy in 964 eyes of over 500 patients. And if you look at these eyes and classify them according to group A, B, C, D, E, and follow them at 1, 2, 3, 5, 10, and 20 years, you can see at 1 year, most groups look pretty good. This holds for 2 years, and 3 years, and 5 years, and 10 years, and 20 years. So basically what you see at 2 or 3 years following intravenous chemotherapy is what's going to happen, what your outcomes will be at 20 years. So I usually tell patients what we see at 2 to 3 years predicts what they're going to have long-term. Now, how often do we need to resort to intraarterial chemotherapy or plaque radiotherapy in eyes that have received intravenous chemotherapy? Again, groups A, B, C, D, E. IAC is necessary in about 20% of cases, and plaque radiotherapy in about 20% of cases. The IAC at a mean interval of 5 months and plaque at a mean interval of 13 months. So generally, about 20% of patients will need these additional therapies to save the globe. Now, regarding risk factors for tumor recurrence following primary intravenous chemotherapy in the same cohort, we looked at this and published this in Pediatric Ophthalmology and Strabismus 2020. When does recurrence happen following chemoreduction, intravenous chemotherapy, for retinoblastoma? Well, you don't have to wait for 10 years to see recurrence. You're going to find most of your recurrence by 2 to 3 years. So tight follow-up within the first 3 years is necessary in these cases. And who's at risk for recurrence? Well, using multivariate analysis, we found younger patient age at diagnosis, greater classification group, closer proximity to the disc, and the presence of subretinal seeds all predicted risk for recurrence and likely need for intraarterial chemotherapy. Now let's move on to IAC, intraarterial chemotherapy. It is a powerful, very effective treatment. You've heard David Abramson give his perspective on this wonderful addition to our armamentarium for retinoblastoma management. We find it best used in exophytic retinoblastoma, especially where you have an area that you can see that there's normal retina, because as the tumor regresses, you're left with a small scar, and in this case, flat retina, and maybe potential for some visual acuity. We're publishing a new report on retinoblastoma intraarterial chemotherapy in 341 consecutive eyes, over 1,200 infusions in the Journal of the American Academy of Pediatric Ophthalmology and Strabismus this year. Here's an example of a very advanced eye in a 3-year-old boy before in plate A and B, and then after in C and D, showing beautiful regression of an eye that would have otherwise been enucleated. Looking at Kaplan-Meier outcomes for globe salvage, let's take 5-year follow-up. Group B, we have 100% globe salvage. C is 80%. D is 78%, and E is 55% globe salvage. Now, these groups D and E would have otherwise been enucleated. Of all the primary IACs, the 5-year globe salvage was 76%, and the median was 3 infusions of IAC, and in our hands, complication rate was only 1% per infusion. Now, a few words about intravitreous chemotherapy. We use this every week in our practice. And we like to use Evomila that Dr. Mounier talked about. This lasts for 4 hours, not 1 hour as the Alcoran lasts. And these are 2 different preparations of melphalan. Here you see before and after intravenous chemotherapy, and then after the addition of intravitreal chemotherapy, we're left with a macula and a clean vitreous. We published our outcomes in 192 consecutive injections where we had 100% intravitreous seeding control. And then later, Jasmine Francis did a collaborative effort where she had several centers contribute their results, and she found there were no extraocular seeding. There was no extraocular seeding in any case, and there was excellent control following intravitreous chemotherapy for vitreous seeding. I think for those of you who want further reading, Dr. Manjan Davida and our team wrote on the role of intravitreal chemotherapy in the Indian Journal of Ophthalmology just recently. Now, we also use precision intravitreal chemotherapy for localized seeding. What does this mean? Well, if a patient has just one little clump of vitreous seeds, we will inject the chemo precisely over the seeding using the indirect ophthalmoscope and visualization. So for example, here we see a vitreous seed sitting near the foveola. So we place the chemo right there in hopes that we don't create toxicity at the foveola. And you can see afterwards, the seed has resolved with little toxicity. So let's move on to our second topic. Second topic being unilateral sporadic retinoblastoma. How do you approach this? So previous publications have said that solitary unilateral retinoblastoma is somatic in 85% of cases and germline in 15% of cases. But it is way more than that, as it depends on the baby's age at presentation. So we looked at 482 consecutive patients with one tumor in one eye, solitary unilateral retinoblastoma to ascertain the percentage with germline mutation. And we divided it and did a comparative analysis based on patient age. 0 to 1 year, 1 to 2 years, 2 to 3 years, or greater than 3 years at presentation. So if you look at this table, for those 0 to 1 year, 29% of children with solitary unilateral retinoblastoma had germline mutation, versus those that present over 3 years of age, only 9% had germline mutation, and this was highly significant. And then if you just look at children under the age of 1 year, those that were 0 to 3 months, 61% of them had germline mutation. This impacts how you might consider treating them. Compared to those 9 to 12 months of age, 22% had germline mutation. Highly significant p-value. So in table format, we see solitary unilateral retinoblastoma in the youngest age group, 0 to 3 years, has the highest risk for germline mutation. So you really have to anticipate multifocal tumors, bilateral tumors, pinealoblastoma, and other considerations for germline mutation. Whereas older children tend to have less risk for germline mutation. And we're publishing this in the Journal of Pediatric Ophthalmology and Strabismus. Last, just a few words on retinocytoma. What is the risk for transformation into retinoblastoma? To be published soon in 2021. All of us are aware of the clinical features of retinoma and retinocytoma. Benign appearing, they look like they're already previously treated retinal tumors in young children. So what happens if you follow these without treatment? So we looked at 78 tumors classified as retinocytoma or retinoma that we followed over 20 years. And we found in these 78 tumors followed over 20 years, at 5 years, 7% showed growth into retinoblastoma. At 10 years, 11% showed growth, and it did not increase at 20 years. Here's one such example. This was a patient who had been followed with what appeared to be a regressed retinoblastoma, i.e. retinocytoma retinoma, but then centrally there was growth. We treated her with intraarterial chemotherapy and she did beautifully. We would advise that all these children have tight follow-up when you first see them. We follow them in 1 month, then 2 months, then we make our interval 3 to 4 months, then Q6 months, and we follow them Q6 months for life. But now, based on this study, in general, if they don't show growth into retinoblastoma by 20 years, it's probably not going to happen. So we talked about in this short talk, what is new? Well, there are very different chemotherapy applications for treatment of retinoblastoma. Unilateral sporadic retinoblastoma in the youngest age group carries the highest risk for germline mutation, and retinocytoma retinoma overall has about a 10% risk for transformation into retinoblastoma. Oh, and one last thought, and this is credit to Dr. Chantada, gene therapy for retinoblastoma. He may make comments on this. Published with a team in Europe, the VCN01 adenovirus that targets cells with free E2F-1, which is a product of the RB1 dysfunctional pathway. It's been tested in mice and rabbits, and it's been now used in 2 patients, and I'm sure he can elaborate on this, 2 patients with retinoblastoma vitreous seeds. It worked, but it leads to vitritis. There's been no infection with the adenovirus, but there's a lot more to do and a lot more to learn. Here's 2 patients from his publication, 2 injections on day 0 and 14. And you can see the top case showing the vitritis and the difficulty in assessing tumor control. And in the bottom, we can see that these seeds right there did show a response following this adenovirus injection. But you know, that's not the first attempt at gene therapy. Dr. Patty Chevis Barrios back in 2004 also had been working on gene therapy. I hope this is the future of retinoblastoma therapy. So I'll end with a comment I began with. It takes a village to manage one case of retinoblastoma, not just at Wills Eye Hospital, a village worldwide. And this includes all of us learning from each other. And over the past 50 years at Wills Eye Hospital, we have been learning and we continue to learn. I'd like to thank you for the opportunity to speak to you today.